us today. Thank you for taking time out of your schedule and joining us virtually. This is Carrie Craven with KCMPA, and I am going to turn it over to Richelle here, who is going to be our guest presenter today.
All right, thank you. So this morning, let me see if I can.
Yeah, is the volume loud enough, Steve and Victoria?
Yes, I can hear her.
Yep, I can hear fine.
I know. On, I think.
It just worked a second ago. Okay.
Maybe I have to go at a certain angle or something.
There we go. I'll just.
All right. So my name is Richelle Beckman. For those of you, I said Beckman, Marting. I haven't been Beckman for 4 years, but yeah, every once in a while that slips out. Richelle Marting. I'm an attorney with Forbes Law Group in Overland Park, and prior to becoming an attorney was a coder in my prior life. So now at the law firm, I do a lot of educational sessions like this for healthcare providers, where we talk about different services that you may already be providing and whether or not there may be codes available to describe those services, and then if there are codes available, whether or not you may be able to get paid for those services. So what Cindy had asked me to talk about this morning sort of piggybacks on a session that we did a couple of months ago, where we were talking about services that are newly reimbursed under the 2017 physician fee schedule that are things like new chronic care management codes, transitional care management, and some of these really primary care focused services that Medicare is starting to reimburse for. So to piggyback on that, Cindy was talking about the CPC Plus program that some of the practices here will be participating in. And one very specific requirement out of the many requirements for that program to provide these alternative visit encounters. And what that means, what options may be available. When you're doing that under the CPC Plus program, you're getting, as I understand, a per member per month kind of payment for each beneficiary or each patient who's participating in that program when you meet all of these requirements. As you're providing the services, you're also billing for those services on sort of a fee-for-service basis. So if we can find a way to meet this particular requirement to offer alternative visits in a way that those alternative visits would let you get that per member per month benefit, but also on an ongoing basis, bill for them, those visits, and get paid for them separately, that's kind of the ideal situation. So I'm going to go through some ideas that I had, but feel free at any time if you think of something that the practice is doing, or want to ask questions about these or how they may actually work logistically. I'd love to have those kind of conversations too.
Can I say something really fast?
Yeah.
So I know this sounds like it's CPC Plus focused, but I also want you to keep in mind that these are really some basic medical home concepts. So the idea of having alternative visits are really basic medical home. And a lot of the requirements that CPC Plus is now making practices accountable for are really basic things that we should have been doing as a medical home a long time ago, but it wasn't really required. It was kind of one of those that, okay, as long as you're doing all these other things, then you can get your certification or your recognition. But now they're starting to move, now they're holding people more accountable at the practice level to say, okay, how are you doing these? So I just don't want you to think, oh, if you're not in CPC Plus, that this isn't for you, because it really is. And to be knowledgeable of all of the measures and the requirements for CPC Plus will really, and if you work towards that, it really is going to elevate your practice to a higher level. Yeah. So I just wanted to say that.
Yeah, and I'll add to that too, even outside of the medical home model, these are services that practices that aren't participating in any of these initiatives may be doing that they may be able to get paid for separately, that we're going to talk about too. So the particular requirement in the CPC Plus program, there are these different categories of measures or goals that we're trying to meet to get this extra per member per month payment. And the idea is to provide more holistic primary care, to be able to reach out, connect patients with community resources. So everything that you'd be doing as a primary care practice plus some, so the CPC plus. The one that we're talking about today is the first one on access and continuity to care. And if you're looking over at track 2 over to the right, one of the requirements for that is that, this pointer will work, that you provide alternative care visits beyond what you do in the traditional office visit model. So these may be things like phone visits, e-visits, going out to see patients in different sites of care. They give, as examples, senior centers, but assisted living facilities, nursing facilities. So it's taking what you do in your practice as primary care and finding ways to connect with patients who maybe can't come to the practice for one reason or another. And again, even outside of CPC Plus, even outside of the medical home, I'm thinking of myself as a parent. If I could call and have a phone visit or an e-visit, I mean, it's just another way to reach out to different populations. And one of the goals here is making that available to people who maybe otherwise would not come into the office. So, but for this e-visit option or the ability to just call in and get the care or the prescription or whatever it is they need, maybe they would just forego all care altogether, where this gives them the option to have that care, and then of course hopefully that leads to better outcomes. Another piece of this are the hours that those services are provided. It's not required that you extend those hours, but that's one option, one way to provide different types of alternative visits other than your traditional face-to-face office visit with the patient. So what I was hoping to do this morning is kind of walk through these different types of visits that are listed in the CPC Plus track requirement, kind of one by one, and what the coding options are for those different types of services, and then for each of those coding options, what the requirements and limitations are. So e-visits, phone visits, group visits, home visits, those are the ones we'll talk about this morning. The first of those categories are e-visits, electronic visits. So one of the benefits of this is it's something that can be done almost in a patient questionnaire type format, where the patient can complete a questionnaire, and if certain criteria are met, the physician may be able to handle, may be able to handle that without requiring the patient to come in. So in practices that I know that have implemented this option, one of the drawbacks to doing it is that not every commercial payer will reimburse for e-visits. Some of them will, and the copay is often lower for the patient. They still have some financial responsibility for those, but the copay is lower, so that's a good thing for them. They get pretty quick response, which is good for them, but for you all, not all of the payers will reimburse for it. Another drawback maybe to implementing e-visits or online visits, generally there's a separate software program that you would want to have for this. So I don't know if any of the practices already have that you're aware of. And I'm trying to remember the name of, there was one that was built into the patient portal that I think St. Luke's used, and that was 7 or 8 years ago, and I can't remember the name of the application, but a patient could be in their portal and then click to initiate an e-visit. Now, this isn't necessarily real-time conversation with a provider. So as a patient, I would be going in and clicking through a questionnaire on what my symptoms were, and if it met certain predefined criteria as a relatively straightforward acute type visit, you know, a sinus infection or a cold or something like that. But obviously this isn't for chronic disease management, but those acute visits that you have a pretty standardized guideline on what the treatment options are going to be. So we go through that questionnaire. If the criteria are met, it gets routed to a provider to then address the patient's problem. Most of the time it's not a requirement for these codes. Well, actually it is. If you look the second line all the way over to the right, it says to an established patient. So that's an important criteria with these, just because we don't want to be evaluating new patients that we've never seen, whose histories we aren't familiar with, and providing e-visits. Also because under state laws, the physicians can't prescribe medications to patients that they don't already have an established relationship with. So that established patient definition means a patient that individual provider who's answering this online questionnaire, either that individual provider has seen that patient in the last 3 years, or any other provider of the same specialty in the same group practice has seen in the last 3 years. So if two docs are both family practice physicians, and Doc A saw the patient 2 years ago, Doc B is responsible for responding to all of these e-visit inquiries that come in. Because that patient has seen another doctor of the same specialty in the practice, we can still do an e-visit for that patient. They would be considered established. For the nurse practitioners, physician assistants, generally if they're practicing in primary care, their specialty would be the same as the physicians that they're working with. But that would not work if Doc A that saw the patient 2 years ago was primary care and Doc B responding to the e-visit is internal medicine or enrolled as internal medicine, because they're different specialties. If that patient hasn't seen another provider of that specialty in the last 3 years, they would be considered a new patient. To the patient or to their guardian. So, of course, for when the patient is a minor, the parent, the mom or the dad, can be completing this questionnaire, and that still works too, of course. One of the keys to this that I think creates some administrative challenges is that whenever you bill for a face-to-face office visit, inherent in that payment that you get, there's a little bit of pre-service work, like scheduling the appointment, checking the patient in, taking them back to the room. There's a little bit of post-service work that's part of that. So if they get labs come back, you call the patient with the results, that's all part of the face-to-face office visit, even when it's happening several days later. So with these e-visits, if this is happening within 7 days of a related face-to-face office visit, then you can't bill the e-visit separately. And I think that creates some challenges in a patient who is completing this online questionnaire. How do you determine whether that's related to an E&M visit 7 days later? Or do you simply say, if the patient's been seen at all in the last 7 days for any reason, then we won't you may let them have an e-visit, but you wouldn't bill for the e-visit. You wouldn't get paid for that e-visit. But to get very, very granular, if the patient was in for diabetes 5 days ago, diabetes follow-up, and today they've got a cold, since that's not related to the visit in the last 7 days, you could bill for that. But trying to figure out when it is and is not related may be a little bit difficult from an administrative perspective. So that's one option, although getting the technology may be a little bit challenging. You don't have to have a separate application or program. So this can be using the internet or similar electronic communications network. If there are mechanisms, do all the practices have patient portals set up?
I think majority of them do now.
Okay, so if they've got portals, if there is a communication mechanism within the portal, that can work. But I think one of the criteria to consider that would probably take provider input is when will they be eligible for an e-visit versus when they don't meet certain criteria, you need to call in and schedule an appointment. Or maybe that triggers a phone visit where you've at least got some real-time interaction with that particular patient. So those are non-face-to-face. And there's a limit on frequency. You can not only are you limited to doing that, you can't do it within 7 days of a related evaluation and management service that was face-to-face, but you also you have got a limit of 1 per 7 day period. So I can't go in Monday, Tuesday, Wednesday, Thursday, and complete this questionnaire or have a communication with the provider, and each of those get billed as an e-visit. As you can imagine, this encounter, unlike an office visit where everything's happening in 10 to 15 minutes face-to-face with the patient, this kind of encounter may carry over several days with the provider and the patient communicating back and forth until there's a decision and a plan of care put together. So once every 7 days is the limit on when you could bill for that. Even if something happens on Monday and for a totally unrelated set of symptoms on Friday, the patient initiates another visit, you could generally only bill for that once. It's also bundled into the global surgical package. So if a patient had a minor procedure in the office and the patient's still within that 10-day global period of the procedure, like a lesion removal or an injection, if this e-visit has anything to do with that procedure, then you wouldn't be able to bill for that as well. So with office visits, there's kind of a 7-day period afterwards. With minor office procedures, there's a 10-day period afterwards where anything related to that could not be billed separately as an e-visit. Although you can still provide it during that period and you would still be meeting the alternative visit requirement for CPC+. It just wouldn't be meeting, kind of the second goal is to also get paid at the time that you're providing that service. And of course, it has to be documented. If you've got the patient portal, do those portals, if a patient sends a message, does that message pull into the patient's medical record automatically? I think we have to record them. Okay, so that's one thing you'd want to keep in mind too. And if you've already got a process for that, when a patient just sends a question via a message in their portal or whatever the mechanism is, you do the same thing here. That would get recorded, all of both sides communication, what the patient says and what the provider says back, would all get recorded and incorporated into the chart. So there's another code similar to that that's an online assessment as well. It can be done through the internet or other similar electronic networks, communication networks, but this one is by a qualified non-physician healthcare practitioner, professional. So for coding purposes, qualified non-physician health professional usually refers to both physicians, MDs and DOs, nurse practitioner, PA. Those are qualified physician practitioners, even though they're not technically physicians. Whenever you see non-physician healthcare professional, for coding purposes, that generally means someone who wouldn't bill under their own name and number. So a registered nurse or a social worker or those types of credentials, and someone who's doing an online assessment. These are also for established patients, so someone who's been seen within the practice in the last 3 years and has the same limitation that you can't do it within 7 days of a related E&M visit or within the global period of a procedure that the provider performs. Now, when I say the global procedure, that's relating to a procedure that someone in this practice has performed. If the patient had a surgery in the hospital that was done by a physician who's not in this group practice, that's okay. You could still do an e-visit the 10 or 90 days after that hospital procedure. That limitation is only referring to minor procedures generally that your providers would be doing for the patient. The 7-day period in both of those codes is referring to calendar days, not just business days. That's a running week period. Then there are phone visits. So maybe if a patient doesn't meet certain e-visit criteria that the providers have and their condition may be something that they want to actually see the patient for, or they're new patients instead of established patients, where the e-visits may not be an option. Phone visits could be an option. They're limited also to established patients. So that's the same definition there, a patient who's seen that provider or another provider of the same specialty in your group practice in the last 3 years. Now, for these practices, do you all have your own tax ID, or are you all part of the same umbrella?
They all have their own tax ID.
Okay, so each individual practice then is a group practice. So if someone's at your practice and sees a physician and then comes over to your practice and sees a physician within 3 years, that can still be a new patient at the second practice because it's a different tax ID. The group practice is referring to the tax ID number. So these are phone visits, and in this particular group of codes, if you look at the top right, it says physician or other qualified healthcare professional. So that's referring to an MD, a DO, a nurse practitioner, a PA, someone who can bill for services on their own, who's providing a phone visit, established patient, and you'll see the same thing here, that's not related to an E&M service within 7 days. So if you're calling the patient with lab results within 7 days of their office visit, you can't bill a phone visit for that. That's related to the office visit, or imaging studies, or that's all part of the office visit procedure or service that you provided previously. Or you could do it for a patient who calls in with signs and symptoms and they get routed to a provider, a physician, nurse practitioner.
Alternative visits
Yes.
through that, because for those practices that we can still bill CPM, we are, that aren't part of CPC Plus, but the others the CPC Plus practices say, we have a care manager that is, that.
Steve, Victoria, are you back with us now?
Yes.
Okay, sorry about that. Phone just disconnected for some reason.
That patients can call, they call her all the time, she connects with them. When they go in, because they have to report on what they're doing to the CMS, can they say, yes, this is one of the things we're doing and that's an alternative visit?
I think so, as long as it's not the things like calling with lab results that all practices are doing, that it's truly taking the place of an office visit. Patients calling in with questions, maybe the nurse goes in and consults the provider.
Even though it's not a billable.
Even if it's not right. I don't believe under CPC Plus that it has to be a billable event. So you can absolutely meet that requirement under CPC Plus with services that you may not be billing or getting paid for separately on a fee-for-service basis.
You don't think it'll fall under like the chronic care management portion of the CPC?
So one of the limitations on most of these codes is that you can't bill them during the same time frame that you would also be billing for chronic care management and those kind of monthly management codes.
You can't bill for it at all.
The chronic care management, you don't bill for
So
it
I'm
at all.
saying, do you don't think that they'll take it as, that should have been a chronic care versus?
I think you're
That's
meeting
what I
two
mean.
buckets. You're meeting your care management bucket and you're meeting your alternative visit.
And you're doing that in a way that allows you to manage the patient without requiring them to come into the office. I think that meets the requirement for an alternative visit, right?
I would think so.
Yeah.
I mean, we fill ours with nursing homes because we see nursing home patients. So we're automatically covered with
Right,
that.
and you get to bill for those. And that's kind of,
How do you expand beyond just being able to say, okay, we're moving past just what we have traditionally done. Now we're incorporating something else as well.
Right.
Right? I mean.
And I think big picture, and I might be wrong, but if that something else can be something you also get paid for, as it's then that's double bonus because you're meeting your CPC Plus, and then for those practices that aren't CPC Plus, they can be getting paid for from payers as well. Yeah.
Okay. Yeah, it just made me think that, could the practices say we are doing alternative visits? And even for those practices that are not CPC Plus and are doing, medical home, and if they're, getting their recognition or if they're renewing, they could say, yes, we provide phone visits that are alternative. So they could get those points for that.
So, and this first group of codes, when you look at the top, it's physician or other qualified health practitioner, but there's a second group of codes that are for qualified non-healthcare professionals that are phone assessments and management. So this would be the phone nurse who's answering questions for the patient if they need to go consult with the provider, come back with recommendations, and call the patient back for established patients. Can't be a new patient, but that qualifies, and if that's taking the place of the patient coming in, seeing the provider, getting those questions answered, absolutely, then I think that phone visit qualifies.
She does that all the time. She has those communications all the time with follow up with a provider, and then, you know, she gets a response, or the team responds to her once they've talked to the provider, and then she can connect with the patient, or somebody from the practice does.
Sure.
So
if this is something you're already doing, you may consider whether that's something you want. If you haven't been billing for it, and a lot of practices don't, that's something you may be able to bill for. One of the reasons that practices may not bill for that could impose the copay deductible on the patients, but the charges are so much lower, and the insurance payments are so much lower that most patients, if they don't have to take off work and they don't have to go get their kids from school, and they can get their question answered, and they end up paying $5 to $10 instead of 25 or 30, and not coming into the office, that's a great benefit. Not all commercial payers may pay for
I
that.
was going to say, I thought I read that Medicare doesn't pay.
Medicare does not.
Yes.
And I don't believe Medicaid does
Right.
either for some of the commercial payers. I want to say Blue Cross of Kansas City, and I might be wrong on that. There were one or two of the major payers that were starting to pay for e-visits, the online assessments, and some of the phone assessments about 8 years ago when I was working in primary care. So more of them may be starting to pay for these, and it's nominal. It's not a huge reimbursement, but if you're already doing it and you could get $5 to $10 every time you do it, then
I don't think Blue Cross, I think they lumped this into that monthly care thing they give you for being medical home.
for the PCMH, yeah, for the quality.
Yeah, I think it's lumped in there, just like transition of cares from hospitals are.
yeah, very well maybe.
And
Then are there
it's
other
lumped in.
commercial payers that you're not part of one of their medical
And they
models,
do pay for like the TCM
Great.
or things like that.
So Medicare does not pay for this right now, phone visits.
Correct.
Okay, and I imagine that will change.
It's
As
very
we go
possible.
into CPC Plus and their requirements for alternative visits, it makes me wonder if they're gonna reassess that.
And when you look at the trends in the last couple of years in the physician fee schedules, the new codes and the new things that they're paying for are very focused on primary care. I mean, the chronic care management, transitional care management, but this year we had a lot of psychiatric care management. It's very possible that that's something that they consider. So we'll know this summer, or you can even send in a comment suggesting that they consider payment for this, because it's part of these programs and things that you want to be doing anyways. And when you do that, there's a quality of care to the patient because they're getting their issues managed as opposed to ignoring them because they don't have the time or the money or whatever to come in. And it just makes perfect sense to do that. And of course, between these two groups of codes, if a physician's doing it or a nurse practitioner, the payment's a little bit higher. So maybe there's a triage kind of process where certain conditions or certain things would go to the provider to call the patient back and have that phone visit. And when the provider's personally doing it, then they document their time and then they bill it under this group of codes as opposed to the phone nurse who goes and talks to the doctor and then calls the patient back. When it's the nurse having that conversation with the patient, then it would be this second group of codes. So both of those are time-based, and you see the time increments are the same, 5 to 10, 11 to 20, 21 to 30, and of course, you're paid a little bit more as the increments of time go on. But for the lowest level, the one on the very top, 5 minutes is a minimum. You want to hit at least 5 minutes, where sometimes with codes, when it says 5, it really needs 2.5, but that's a minimum. So in documentation of these visits, having the time of the call is really helpful. And we keep track of our time at work. One of the things I do when I'm on the phone is I just, right before I hang up, look at the phone, and it shows me, how long I've been on the phone, and I just write that down. So particularly if you're getting that specific 6 minutes, 7 minutes, that's great. It shows exactly how much time that you're spending on that discussion. And of course, it's medical discussion, not, oh, hi, how was vacation, and I hope everything's going well, but, medically necessary conversation. And I say that because I had a doctor that I used to audit that loves fishing, and his patients tended to love fishing. And so we got a lot of documentation in his notes about how they had these extended visits. And when I was talking with him, he's like, oh, yeah, well, we talked about her mom, we talked about vacation, we talked about their last fishing trip. Okay, that probably doesn't count in your time of medical discussion with the patient. So those are some coding options for e-visits and for phone visits. There are also several options for group visits, and group visits is a type of alternative visit that you can consider under the CPC Plus program as well. And even outside of the CPC Plus program, these visits are getting paid for more and more by different payers. The first group of these is just education and training for patient self-management, and the provider that would do these are the qualified non-physician professional. So these could be diabetic educators, they could be nurses, but generally someone who's not a physician, APRN, or PA. So they could do it, they're just not valued and paid for a physician, NP, or PA to provide those services. One of the components of this to keep in mind is that it requires a standardized curriculum. So like diabetic education has a standardized curriculum. There are different codes for diabetes education that are very specific to different payers. But if a payer doesn't require a specific code, this is an option. These particular group visit codes are face-to-face, so this would be in a classroom with a group of patients. I will mention too, whenever we're talking about group visits, different payers, group obviously means at least 2. So even if you schedule a group session and only one person shows up, that's an individual session then, not a group session. Group means a minimum of 2, but the maximum is different for different payers. So for example, in a different group of codes we'll talk about for, I think it's nutrition therapy that can be done in the group setting. Medicare would allow you to have up to 20 individuals in a group, but Missouri Medicaid would only let you have a maximum of 8. So if anyone in that room had Missouri Medicaid, you could not bill for it unless there were only 8 or fewer individuals in that group. So knowing if there are any limitations from the individual payers on the maximum group size, because obviously the idea is we don't get an auditorium full of people and then bill for a group session for 500 people. They still want, to some degree, some interaction with the individuals in that group session.
Yes, I have a question about that.
Yeah.
So what you're saying is, if we have a diabetic educator or a dietitian that's holding a group class, then all we need to do is provide the names of those patients that came and then supply that to the practice, and the practice can submit for reimbursement as a group for each patient.
Yes, each patient would have one of, so if I am an individual patient that participated in this class, and in that class there were 2 to 4 total individuals in that class, then 989.
And that's Medicare, right?
No, Medicare for those specifically has different codes for diabetes education and nutrition therapy.
So Medicare will be different, but this would be any other payers.
Could be any other payers, or it could be things that aren't related to diabetes. This could be a class on chronic kidney disease, where there are no more specific codes, or I don't know, general blood pressure monitoring, or PPINR for patients with AFib on Coumadin or something like that.
And so the person teaching the class doesn't have to be employed by the tax ID number.
Not with these.
No. So we need to record.
Yeah.
Because you're already doing that at my job.
We're doing that at Northland Family Care. We're doing it at Berry Point. We're hoping to do it at Cobblestone.
Okay. What types of, what's the
Our diabetic
topic?
educator.
Okay. So there are specific codes for diabetes education that would be different than this type of education.
Medicare dietitian, so then she might have some, around nutrition.
So there's Medicare does pay for diabetes education in the group setting. There are some frequency limitations to that, and Medicare would only pay for it if it's a certified program under, is it ADA, that does the Diabetes Association and accredited diabetes education program. And in that case, Medicare would pay for it. But other payers may pay for diabetes education, even if you're not accredited as a diabetes education.
But we can still bill just as a general group visit.
Yeah.
No matter what the topic.
Right.
Okay.
So there's no limitation on what topic this is, as long as you're using a standardized curriculum. If there's something out there, how to educate patients on monitoring PCI&R or, you know, diet, exercise, and how that, absolutely, yeah. So and this particular group of codes has a maximum of 8 anyway, so some of the others can be broader. Another thing that I'd look at when you're billing these services, if you have any commercial payers that will reimburse you for these, are any frequency limits that those payers may have. So Medicare has, you can only have a certain number of group visits in a year, and some of the other payers may say, you know, you can't be doing this every day or every week even. You've got a combination of individual and group visits, and you've got a limit per year. That could also be, you probably heard at the session a couple weeks ago, dependent on individual plans. So it may not be Blue Cross Blue Shield says you can have 10. It may be each employer's health insurance plan. Some have 10, some have 12, some have 15. So it could be different per person. And maybe that's part of the enrollment process as they're signing up for these classes, is figuring out what limitations, if any, they may have if you're going to be doing a series of classes.
You're already just doing it for free, having to write it off every other session wouldn't be a big deal.
Right.
You know,
Sure.
If you bill it and it's declined, then you just say.
I mean, I just look at it too, as we're doing this, so why not provide that list of patients to the practices, so the practices can at least get some reimbursement out of it.
You know, when we were doing similar things,
They're not, it's things that are happening already.
Right.
And it's not taking any extra time for the practice. They're not putting any extra
So
resources.
this is just group, but what if you have one-on-one with the dietitian?
yeah, so there
Okay.
are also individual codes for individual sessions.
And that
as
goes
well.
the same way. She doesn't have to be employed under our tax ID for us to bill it.
Correct. Right. So, and because you're talking about some of the chronic care management and that clinical staff person's time.
Well, I'm talking
They're
about
not
even the
employed.
dietitian that comes in
Yeah.
through the,
Because she's not employed.
she's not directly employed under us.
Employed through KCMPA.
Yeah, that's
To the organization,
Right.
and then
Right.
that all the clinics are a member of KCMPA.
Now, from a credentialing perspective, she may need to get credentialed through the plans at each practice. Are the contracts with payers done at the KCMPA level
No,
or the individual
individual
practice?
practice.
Okay, so the credentialing is another piece of that may have to happen, and each payer, I've got a matrix I can send you on. I did some research on this within the last 6 months on particularly diabetes and nutrition education, which of the big payers wanted those professionals to go through the
At
credentialing
least be
process.
listed under you.
Right, and the sites where they're going to be providing those services.
We can talk about that.
Yeah.
But not all of the payers wanted that, some of them did. Let's see, did I go backwards? Okay, curriculum. Each 30 minutes, okay, this one, when it says each 30 minutes, 30 minutes actually means 16 minutes.
Oh.
So if you're doing 16 minutes of education, that counts. And where it says each 30 minutes, then each 30-minute increment, you would get to report this code for each increment. So if you've got, so there's the individual patient code up at the top. But if you had a group of 2 to 4 and you had a 1-hour session, then you would report 98961 times 2 for each of the patients that participated in that group education session.
Are you going to send this slide?
Yeah,
out?
yeah, you're welcome
I just have
to share it. Yeah.
Okay.
And from a billing perspective, it may take some time to figure out which payers are likely to pay for these and which ones aren't, because sometimes they don't post that information online and make it available, or when you call, you can spend 3 days calling these payers and they're going to say, it depends on the individual plan. Well, if you can bill for them, at some point you do a data analysis of every time we bill for these codes and then which ones are we getting paid. Are there any payers that were never ever getting paid? And maybe you decide it's not worth it to bill and then write off those charges for certain payers, but if there are payers that do tend to pay for them more frequently, then you can eventually figure out what makes the most sense from a billing perspective.
Going to the grocery store, could you use that in some way? In like a group setting?
Probably. So we're we're discussing creating, or we're actually in the process of putting together a sort of a healthy living weight management 8-week program. And we'll probably do kind of address two audiences. One would be employees of KCMPA, because we kind of have our own health plan.
Sure.
So it would benefit us to say, hey, you know, these are some of the things that we're doing within our own organization, and, you know, so that they can look at claims down the road and look at outcomes for our own employees, just for pricing, those types of things, right? And then we're also looking at it for patients as well. And so, you know, having some certain criteria around what patients would be referred to this program. So is that something that, you know, we could be able to build for each one of those sessions?
Right, where are the sessions provided?
So we are looking at places that have, like churches that have a kitchen. So that we can do, you know, instructions and how you cook and how do you make recipes. We're looking at going to grocery stores, you know, so that we can show patients how, I say we, I mean our dietitians.
Right.
You know, how do you shop, especially in areas that are, you know, food deserts. How do we find and shop, you know, for healthy food? And then also, like going to restaurants. How are you able to go to a restaurant with your family that make good choices?
Right.
So that's the kind of things that we're looking at.
So two things to think about is, one, for these, it would have to be a standardized curriculum. If there's something available for that. Okay, so meets that requirement. And the other would also be the credentialing aspect of the payers knowing the site of service, since it's not happening in your office, that would be a billing aspect where you'd have to indicate where the service was provided and the address of the church. That would go on the claim, and then the payer would need to agree that that's an acceptable site of service.
So if we put that, I mean, we'll have a formal agenda. Everything's going to be all lined out before we do this. So if we provide that to the clinics, then the clinics can take that to their payers and say, hey, we're going to have this available. What would you reimburse for this?
Yeah.
And then once again, that would be something that it would really only be that billing piece, and would not take any time away from the providers.
Do you have to have some form of something in their medical record for it?
Yeah, I think a notation that they participated in the session, but if you've got a standard curriculum and how long those sessions are and the content of what was discussed in those sessions, then that's sufficient. So that the dietitian or whoever is conducting the session, I don't think doesn't need to type that out in detail for everyone, but maybe there's
But just scan that one thing in.
template or something, like session 1, this is what we talk about, so I enter session 1's description for those 4 to 8 or however many patients participated.
Okay, that's good. That's good information.
And then, of course, you'll want the duration in there, because that does affect the coding perspective and how many units.
So we'll be able to take this to like Blue Cross and say, you know, would you cover your patients for this program?
Yeah, and there are codes. These are the CPT codes, but Blue Cross also tends to utilize codes that start with an S from the HCPCS book that also describe a lot of services like this. So they may have codes already that they would prefer in lieu of these that describe essentially the same thing. Another group education service. So this one's done by a qualified non-physician healthcare professional, like a nurse, a dietitian, nutrition professional. There's also an option when it's done by the physician or the APRN or the PA themselves when they're doing that education and training. So prenatal is, we didn't talk about that one, but that's another option. If you had a group session on prenatal care or breastfeeding classes or those types of things, you could offer and potentially bill for as well.
Like any of our clinics
Obesity.
do babies or prenatal, they refer them all off.
Okay, to the OB, all right.
Nobody here does, right?
We've got one OB at Sunflower.
Okay.
And these run into the patients in a group setting, so you don't see the groups of individuals, like how many individuals constitute a group here. So another thing to think about is the providers are actually doing this, which it sounds like that's not the direction you want to go. You want to have non-physician practitioners doing these so the providers can focus on the patients in the clinic. But if they were doing it, you want to look at each payer and what's the maximum number in a group that we could report for that. So under nutrition therapy specifically, there are codes for that, both in the CPT book, but also this is a code that Medicare specifically uses for nutrition therapy, and Medicare does pay for nutrition therapy. And you don't have to be a certified diabetes program. This can be nutrition therapy for obesity, diabetes could be one of them, but other conditions qualify as well. And Medicare allows up to, I believe, 20 people in a group for the nutrition therapy. Missouri Medicaid limits it to 8. So again, kind of knowing who's in the classroom. If there were 20 people in the classroom, one of them has Missouri Medicaid, you wouldn't be able to bill for the Missouri Medicaid patient because you've exceeded the number of people in a group that Missouri Medicaid would allow.
So for let's say, for weight loss, or we could, since we're currently doing group education, this is what we would bill for each patient under Medicare. And it's a G code, so there would not be any patient fee.
I'll have to look at that. I don't remember if I don't know, some of the G codes don't. This one, I think it does apply to.
It would probably go towards their deductible. And
right, I don't think it's waived from the financial responsibility the way like an annual one was in the program are. But I think the dollar amount's much smaller than an office visit. And there are also frequency limits for Medicare and Medicaid, each payer, on how many visits each patient can have.
Or a picture of that.
So many smiles and with a picture.
Yeah.
And then each 30 minutes. These are other options that Blue Cross tends to cover S codes. So these are some of the codes that Blue Cross tends to prefer in lieu of Medicare's G codes or codes from the CPT book for whatever reason. So these are different types of, there's nutrition classes, there's specifically weight management classes, which may be, exercise in addition to just nutrition counseling. I think all of these are non-physician providers. So these could be your nutrition professionals, nurses, but
are test codes reimbursed by CMS, or is that other payers?
That's other.
These are typically other payers.
Okay, I was going to say, I'm
yeah,
not
so
familiar,
these are not Medicare, but Blue Cross, these are ones that Blue Cross tends to select and want their providers to use as opposed to G codes, even though there are G codes that describe these services that Medicare doesn't pay for.
Well, this is still really good to know, because that means anybody can, all patients can be referred to the group classes, and then we submit that list to the practices, and then they can determine which ones can be reimbursed.
These, actually, I'm looking at my notes here. The references to the clinical policy bulletins are Aetna clinical policy bulletins, so Aetna pays for each of these. And there are some restrictions, and patients have to have certain diagnoses, but it's, for weight management, it's obesity. They're very, the diagnosis restrictions are not terribly restrictive. Patients that you would be directing to these classes most likely have conditions that are going to be covered in these classes. Exercise classes specifically, and the nutrition classes. So all of those may be options under Aetna or some of the commercial payers. These are, and they're per session. So one of the difference between these codes and some of the others is that some are time-based, where these you would report once per patient per session, regardless of whether it's 15 minutes or 3 hours. So some other care settings, we talked about seeing patients in the nursing facility, so that qualifies as an alternative visit under CPC Plus. Plus, you get to bill for it separately as an evaluation and management service. Home visits are another option. There are evaluation and management codes that you can use to describe home visits as well. And home visits are classified based on whether the patient that you're visiting in the home is a new patient or an established patient. And those visits need to be done by a physician, nurse practitioner, PA, someone who's qualified to bill for those services on their own. And they don't describe, they're not used for home health agency services. It's when your providers, where the site of service just happens to be in the patient home instead of them coming here to the provider office. And then again there, the definition of new patient versus established patient is whether they've been seen by another provider, same specialty in your tax ID in the last 3 years. Those codes, I don't remember in January if we talked about deciding levels of service, but the distinction then is for new patients and for established patients, how complex was the visit? And that's really based on the provider's documentation of what history they took, what kind of exam that they do, how complex is the decision-making to determine which of those codes that they would report. There are also codes for visits that are done in assisted living facilities. Skilled nursing facilities is a different category, but almost any site that you go to, there are evaluation and management codes that could be reported for that. One of the things from a credentialing perspective is if you're going to, like I think we talked about schools a couple of weeks ago and whether that counts, is credentialing with the payers, so that if I go to a school or if I go to a senior center, what codes, what site of service do they want us to report for those? These are easy because there are groups of codes that describe specifically visits in assisted living, but there's not a group of codes that describe senior center, which is not, you know, a health care setting, so that the payers would have to tell us what groups of codes they want us to use, and then with those group of codes on every claim, there's a place of service, an additional place of service code that we report. It's a 2-digit code. Let me see if I've got, I don't know if I've got them in this book or not. I don't think I do. But office visits have their own codes, and then there are all of these alternative types of settings like retail centers that can have a place of service code too. So there are ways to do it, but each payer, since that's not a dedicated healthcare setting, they have a different way that they want you to report those if you're going to go out to senior centers and do visits. Another requirement, often when you're going to facilities like assisted living or to skilled nursing facilities, you may be required to have a dedicated space where you're seeing the patient. Sometimes the payers don't want you to go into their individual room. Sometimes they want basically a physician office in those settings before they'll pay for them. For assisted living or going to skilled nursing facilities, those codes aren't used for patients that are being seen by home health agencies. They're not used for patients that are under hospice care. So those are truly, instead of coming to the physician office, the physician is taking them type visits. Oh,
Maybe coffee pot.
maybe I was looking at the doors open.
It smells great though.
No way.
So one of the last categories or ways that you could also meet the CPC Plus program are extended hours. So not just different ways that the patient can reach out to you via technology or phone or sites of service, but when they can reach out to you. These codes can be reported in addition to the basic service. So if you've got an office visit that's happening at 8 p.m., you could report not only the office visit code, but let's see, not regularly scheduled, the 99050 services provided other than regularly scheduled office hours or days when the office is normally closed. So patient has an emergency, I took the provider or the office typically isn't open on Saturdays, but the provider says, meet me at the office at 11 and we'll have a visit, that would qualify. But if you open your office hours on Saturdays from 8 to noon, then that is a regularly scheduled office hours. So you could no longer report a code saying that you've provided a service outside of your normal office hours. For payers like Medicare, on your enrollment forms, you put your normal office hours on there. So you'd want to make sure that you verify that information is up to date. And if you were going to report a code for an extended office hour, it is truly outside of the time that your office is normally open. You also have options if you look at 99053, something that's done between 10 p.m. and 8 a.m. In a 24-hour facility, or 990, I guess we wouldn't be a 24-hour facility, 99051 during your regularly scheduled evening, weekend, or holiday office hours. So if you're open until 8, then that's an evening office hour. It's regularly scheduled, so you could report your office visit and could report 99051 in addition to that. Actually, it might have been Sunflower, I think, was billing for those services, maybe. And United, I believe, was paying for them at least, and maybe some of the other payers for some of these that are billed in addition to the office visit. So could be separately payable by your commercial payers. It's not going to be paid by Medicare, Medicaid, and could meet that requirement for providing alternative visits under the CPC Plus program.
What are they considering evening, after 5 p.m.?
Yeah, it's not defined from a coding perspective, but I'd say, yeah, probably after 5 would be a good benchmark to use. So if your office, if you have late evenings, early mornings, weekend, if any of the clinics open on Saturdays for walk-ins, then those would be perfect candidates to consider reporting these as additional codes. And while United tended to, the last time I looked anyways, reimburse for these, some of the other payers may, or they may say it's going to depend on the individual plan. So it's really going to be hit and miss on whether the commercial payers will pay for it. But that's another thing. You can bill for it for 3 months and then go back and kind of analyze the data and see who is, who isn't, how much are they paying for these. If, let's see, normally closed, 99058. I don't know how often this would happen, but if there's ever an emergency in the office, a patient crashes or a patient falls, that takes a lot of resources and pulls providers away from their other patients and you're taking care of them, that could be an option to report in addition to the base evaluation and management service. But probably I would say the 99050 and 51 are the two that could be more beneficial on sort of a global basis as additional services. Okay, so anything else or other questions on alternative visits or alternative sites of care?
Yeah. And I think I presented this at the KC Digital Drive meeting. So what are the restrictions? Let's say you just want to set up a Skype. And you want to Skype back and forth with your patient. So let's say every Friday morning from 9 to noon, I'm going to do Skype patients, a year. You have a provider that will just do that. Is that acceptable? And is that acceptable as far as a privacy and HIPAA compliant? If you're in an office and you just and would that be alternative and telemedicine? Do we have to invest, if we want to go into telehealth, do we have to invest in, expensive types of, equipment where we go into contracts with people? Or let's say we want to set up a social worker with behavioral health, and she can sit in an office and in the practice, and she can meet by Skype with patients. Or Rachel's like, oh my God, don't make me Skype with people. but I'm just using that as an example.
Okay, so with the first piece of that, the Skype and the privacy and security, when you're doing the practice of security risk assessment, that's just one of the things you want to consider. What is the security or lack of security on them? You'd probably also want to get the patient's consent and recognize that, the Skype may not be secure, that someone could, I guess, hack into that session, or pieces of it may be recorded somewhere. But it's the same thing as an unencrypted email. If the patient wants you to communicate with them in that way, you can tell the patient, we can do that, it's unencrypted, there are some risks, and they say, I don't care, send it to me anyway. You do that, you document that they gave consent, and you could communicate with them that way. From my perspective, I think Skype would be similar. You want to have as many precautions on your end as possible. You want to make sure the person on the other end is the patient, obviously, and as best as you can that they're in a secure area as well. And although if they want to Skype with you at Panera or Starbucks,
That's their choice.
that's
on
yeah,
them.
their choice. And that could be an education thing. If you pop it up, you could tell they're in a hotel lobby or something. Say, is this a good time? Do you want to call back later when you've got some more privacy? And if the patient says, oh, no, let's continue, probably make a notation. They've given consent, but I'd also make a notation of that, that I have concerns about privacy, that the patient wanted to continue in the record.
Skype is encrypted and secure.
Right, so
So,
all
but
of that.
with everything else, they do still have that risk that it could be hacked. or
Right.
whatever. But
And
they are
I think
secure.
if it's Skype or whatever technology you're using,
But-
documenting that this is what we selected, this is what we researched about it, this is
But a
the
lot of
security
And it
measures
is-
we know they have in
Yeah,
place.
maybe you're seeing-
We educate the patients about it, but having that documentation will
Yeah.
be.
You know what, a lot of times, they don't want to get into practice. Like,
Yeah.
if this is an established, patient,
Mhm.
and maybe there's just something little, it's like, I need to talk to my doctor. I mean, do they always want to get up and go? May have to make an appointment, take the time out of their day, take time off of work. And everybody has a phone, which has Skype, webcam,
Right, that's
and
true.
FaceTime.
But still,
And
you have to be
FaceTime's
careful.
encrypted.
You really do. You have to be careful because then what phone services are they with?
I wonder if that'd be an opportunity to have one of these educational classes.
That would be good.
Talking
That
about
would be good.
patients, how to use these devices to manage their care.
I'd say do that, do an educational course first before you start doing that because you're opening up cans of worms because of HIPAA and a lot of other things. So you don't want to start something without doing your homework first. I do the educational course first, then see how equipped the person is, if they're savvy enough to do it, because you really don't want to start doing that because there's a lot of stuff going on with these iPhones. It's just, to me, it's a risk.
Sure, and it's interesting that I think it's interesting because the physician that came and spoke at KC Digital Drive, he's been pushing for 30 years that we need to move to telemedicine, and that there's to do remote and to do distance. Why can't I mean, he was just, and this is a little exaggerated, but he's like, I'm a retired physician. Why can't I sit in the country club at the golf course and pull up screens and see somebody else's patients that, they're on vacation? Why can't I be doing that and address those needs? And his thing is that as a whole for healthcare, we're so afraid of HIPAA and we're so afraid of, that we're such a legal, we're so afraid of getting sued and all of that we haven't moved to that. So that's just.
But you know what? I just finished RN courses. So there's a telehealth monitoring that we had on the exam. There's a physician that does the telehealth monitoring with patients that are in the rural areas, not the urban and the suburban,
they do.
but they're doing it now.
Oh, yeah.
But it's within the patient's home. So they're at home and there's no one there but just them, and then the physician is on the other end. But I wouldn't do it personally out in public. I wouldn't do it at a Starbucks or anything, but I would do it in my own home because there's no one there but me.
And I think that was.
And I think it's a wonderful
if you
thing.
have an appointment at 9 o'clock and your patient calls into your Skype session and you see patients out in public, do you want to do this right now?
Yeah,
And, I mean, if the patient wants to walk around and Skype for whatever, then that's, as long as you're doing, as long as on your
Tell the doctor
end,
about their rash.
Yeah.
Right,
He
right.
show you.
as long as on your end, you know, your provider's not the one out in public doing
Right.
it, and they've got a
Right,
secure area,
right.
the system you're using, you've researched, you know that it's encrypted, and you kind of document the security measures that you've got. You make sure you know whether it's being recorded in any capacity and where and how that may be done, how that's being documented and translated into the medical order. All of those things, it can be done, and still be, from a security perspective, HIPAA, this is the same as HIPAA compliance, but could meet the HIPAA standards. So the second piece of that on compliance, can we bill for it? You mentioned that they do it in rural areas. So Medicare, for example, would only pay for it if the patient is located in a rural
That's
area.
right.
And what they
Right.
consider to
There's
be a rural area.
no offices nearby in the country, in the rural area.
Right.
Yeah.
So that's I think one of the challenges in our area,
Is
whether
the
the reimbursement piece, and whether someone like Blue Cross, maybe because they're obviously on board with some of these technology innovations we heard at that meeting, but whether they would allow you to call to a patient's home. I mean, to me, it makes perfect intuitive sense to call someone in, you know, that maybe in an urban area or in Kansas City that if they've got it on their phone and readily accessible, they're going to get health care when they may forego it otherwise. But that's just me. But the reimbursement piece would be the other aspect of that, and whether the payers will allow you to do it, particularly when the patient's not in a rural area. It's kind of the biggest reimbursement challenge for us right now.
Well, and he gave a really good example too, you know, about if you have a child that has a frequent ear infection, and you can get a device called a stethoscope. It connects to your iPhone. You can put it in the child's ear, and the physician can pull up his phone and look at the child's ear. Right. But the biggest piece. So and they have different thermometers now. There are thermometers that connect to your iPhone. You can take the child's temperature. You can, you know, feed that to your provider. But the piece is who's going to pay for that, because that's really a visit. I mean, they're really, unless you physically go in and you. So that's the other piece of, I think, if we can start getting that paid, I think that they would start moving towards that. I really do.
And on that, I think that adds additional security considerations in how, is there a program, or how is that data on temperature getting transmitted, you know, from patient's phone to the provider's phone, and how that works. And that's also another piece on an e-visit. If you're using Skype or FaceTime or whatever it is, and the providers obviously use their clinical judgment on if they're limited and they can't visually see the ear, if it's the sniffles or it looks like upper respiratory and they can do that exam by e-visit, fine, but there may be things that they say, you know, you really need to come in for. So, and when that happens under these codes for e-visits, if it's related to, if as a result of that visit you schedule an appointment within the next 24 hours or first available appointment, then you wouldn't be able to bill for that e-visit either. But I think the reimbursement, that certainly would qualify as an alternative visit under CPC Plus, but whether or not that also gets paid
is a whole different. So for CPC Plus, and it's going to be dependent on what that patient, if it's a Medicare or a Blue Cross or, you know, one of those that's falling under the CPC Plus umbrella, they would get that care management fee anyway, and then meet their alternative, that criteria. But it's still going to be, I think, until they really start reimbursing for that, it's going to be, that's going to be something that is going to be a big challenge.
And they may, when the Blues and Aetna do start reimbursing when a patient's not necessarily located in a rural area, I think it's only a matter of time, but they may also implement certain technology requirements along with that.
Yeah.
Would you be able possibly to do some of like the still be billed for like TCM visits if it was like a e-visit or a phone one?
So those require a face-to-face office visit within a certain either 7 or 14 days after discharge from the hospital. But the other management activities that are going on in that 30-day period can certainly be done non-face-to-face or via a telemedicine type visit, and there wouldn't be restrictions on that.
I always have a ton of questions.
No, that's okay. The discussion of what the practices are doing, I think, is really good. If there's something that you're already doing, that there may be a code and a way to get paid for it, even if it's only your United patients or only your Aetna patients, it's still maybe
Well,
you're not
for
already.
you too, because you're using Mary Jo, that's huge.
She's there every Wednesday, and we've been trying to get her, keep her schedule booked.
Yeah.
So, yeah.
So there's codes I think we can use to reimburse the practice and be reimbursed for what she's doing.
Okay.
Which I think we can probably talk about that maybe one off because it's so individual.
Okay.
And also, the doctors were bringing new diabetics to Mary's office, and Mary was doing some counseling with them as well, and some diabetic teaching, but we also would sign them up to see Mary Jo also. So they're going to probably start bringing people in to see me on the opposite days that Mary Jo's not there. So how can I bill for that if I'm doing some counseling?
So there are also options when the patient has had a face-to-face visit with the provider that day. Maybe we find out there's a new diagnosis of diabetes. So they take the patient down the hall to have this education session and learn about the condition. There is prolonged clinical staff time, if I can find those codes. I think they can be billed on the same day.
It's like an extended visit.
Right, and it's for clinical staff time, not the physician's time. There are different codes for physicians: prolonged service time, prolonged clinical staff time, beyond the typical service, during an E&M visit in the office, physician supervision, which just means the physician's in the office. So if you have at least 31 minutes, then that would qualify as clinical staff time. So you could report 99415 in addition to the provider's office visit code.
Okay.
And I didn't introduce Regina to everyone, but Regina is the new care coordinator at CMG. Mary retired, and she's getting married and moving to Florida to live on the beach.
Isn't that something?
I'm tired. I
So
know,
we'll
right?
be seeing lots of Regina. So it's good.
I have a question for you. Okay. Yesterday, Dr. Kaduri brought me an individual back for chronic care management. They had an office visit, and I asked him, they did not have a TLC today, did they? They didn't discharge from the hospital. No, they didn't. So I brought him in the office, and this was my first time doing it, and I hope I did it right. So I sat down and did like an assessment and some paperwork that I did with the patient, asked questions and set some goals and stuff. Is that billable the same day since he had an office visit?
For a CCM?
Yes. So you can't bill that?
Month, 30 days.
Okay.
You
Okay.
have to have a certain amount of time within a 30-day.
But there is something that you can bill for that.
Okay.
She just talked about.
Okay.
But I believe the CCM, so if it's a CCM and gets referred to Rachel now,
Okay.
you won't be able to bill that
Okay.
until next month.
Okay. So
Well, it'll be Rachel's business, not yours.
So give it to Rachel, because he signed all the paperwork, the consent forms. I explained to him about the billing. I let him know up front, so he was like, I don't care, I'm fine. So you coming over tomorrow, aren't you? Good, because I need some help with the CCM.
Yep. So you know that they don't have to sign a consent form anymore. All they have to do is be a note in the chart.
Okay,
I'll send you
okay,
that updated.
We'll get through it for you.
Yeah.
okay, good.
CMS and I'll send you the webinar that they did.
Okay.
They just did an updated, they did a webinar on the new codes for CCM.
Okay,
So you don't have to sign. Now, we do have a practice that is still continuing to do that just because it works for them,
okay,
and they have a process, and it doesn't matter. But you
Okay.
don't have to have them sign All you have to do is just note in the chart that it was discussed with them.
Okay, that's what I need to know, so I guess we'll do
So
that
that could
tomorrow.
be, for your visit yesterday, prolonged clinical staff time 99415 if you spend at least
Oh, it was 30
31.
minutes. It was,
31, yeah.
okay, it was like over 30 minutes.
Okay, so, and you'd want to document how much time that you spent because that code is time-based.
Okay,
So if it were ever audited, someone would want to verify that when we build that code, there was at least 31 minutes. If you put it there 35, 45, whatever,
Okay.
that's fine.
and I did document it in the CCM documentation. Y'all, I don't know what I'm doing because we didn't get a chance to do it before she left because no one wanted chronic care management, so I just took a stab at it. I said, okay, let me just do it.
And that's fine, because it's still documented in the
Right, it
chart.
doesn't matter where it's done.
Yeah,
Okay.
you still have it, so
Okay.
it just can't be billed under the CPT code or
Okay.
CCM.
Okay,
But you can bill for what Richelle's saying, that extended visit.
okay,
But then now, when Rachel meets with that patient, she'll be able to, or if you did, and you did CCM in 30, I think it's 30 days. Am I right, 30 days?
It's for a calendar month, but as soon as you have 60 minutes of clinical staff time and you've done all of the other things, you can bill for
oh,
it.
I see what you're saying, so it can't be billed until next month.
It could be if in this calendar month, you meet all of the requirements, you have at least 60 minutes of clinical staff time, it could be billed this month
For the,
for CCM.
Okay.
As long as it wasn't the same month as the transition of care from the hospital.
Right, because you can't do
Right,
it, if it's a transition of care, you gotta wait 30 days, and I do
And
have
that's
some
maybe I'm
that I need to wait.
between transitions of care and CCM.
The transition of care, you cannot bill until the 30
So the
days.
CCM can be,
As soon as you hit that time threshold, you can bill it.
so it could be the next day.
It could be, if you spend an
This
hour.
patient, this patient did not discharge from the hospital, he was just coming in for a follow-up visit, for his 3-month follow-up. So they brought him back to me and said, hey, we want him on chronic care management. So I sat down with him.
So Rachel can meet with him today
Okay,
and bill for that.
okay,
You can bill for that. But you
Okay.
couldn't yesterday.
okay.
Because he had his same,
That's what I wanted to know.
the same day. Yeah.
Okay, so should I have
was
set him
confused.
up after, should I have just called him on the phone after, like today instead of doing it yesterday?
No,
Not
because you
necessarily,
can
your
still
time
bill.
still counts.
Okay,
So
okay.
you spent
I've spent over 30 minutes with him.
okay, so let's say 45 minutes. So you document your 45 minutes, and then
Okay.
if tomorrow you spend 15, we've now hit our 60-minute
minutes.
threshold, and then
Okay.
we can bill for that. So we want to make sure your time gets included.
Okay, okay.
Yeah.
Okay, because I gave the doctors a form, they were already using a form with codes on it, and I told them, I said, if you want your patient to be on chronic care management, I need you to check the box down there with chronic care management. So when you bring me these forms in, I know that this patient is the one that you want on chronic care management. So I'm already working on some things with the doctors. I've spoken with all of them. Yeah, I'm getting things lined up. So we're gonna have a lot of patients. I already have hired like 6 of them, but we can't do it until 30 days out. So I've been writing on there. Okay, May the 11th, May the 15th. Yeah. So.
And you can be, because you mean they've done the transitional care?
Yeah.
Yes.
I see, okay.
You can, yeah.
Well, and we can look at other criteria. Sorry, I know we're kind of getting, but I think these are good discussions because we can look at other criteria
Okay.
for what would be a good CCM patient,
Okay.
or a patient that would fall into a care management. You know, I don't know what you guys, I know you guys aren't doing CCM itself. You're doing chronic care management. You're not billing for the code, but you still have to have criteria based on CPC Plus for who's working with your care manager here at Clay Flat. So do you know what that criteria is?
Not, since it's changed to CPC Plus, no.
We haven't gone over that, like, in quite a while.
Are you guys doing risk stratification?
Are
No.
we still doing?
We were.
Yeah, I don't think that we're doing that.
Yeah,
Yeah.
but we have not been since, we haven't.
We actually, since it's changed, we haven't had a discussion about what we're doing or what we're not.
Okay.
That hasn't been discussed with us yet.
Exactly.
So one of the things that we can talk about too is, now, are you guys doing the risk stratification?
We haven't started yet.
Okay. So would that be helpful if we maybe do a session here on risk stratification and what those tools are and how you risk stratify and kind of what some other people are doing and, sorry, I know that.
Yeah, no, good.
Would that be helpful maybe at the next
Yeah, I think
Good
it would
for
be,
anything.
Okay. And how you would determine who goes into a care management program, who needs to work with a care manager based on that, or other resources as well. I mean, there's, tons of resources that we need to be providing for these folks that maybe fall into those higher risk levels.
Yeah.
Okay.
So before we get any further off track, I think Victoria on the phone had a question for Richelle. So Victoria, if you want to unmute your line and ask your question, you may do so now.
Hi, can you hear me okay?
Yes.
Okay, this is Victoria. I have a question about the billing for the group education visits. If the group education is done by an outside provider or an outside group, outside the practice. I was a little confused about who then was eligible to bill for those group educations. Would it be the group with the diabetic educators that came in and did that, even though they're not employed by the tax ID? Or would the practice then go back and bill for the work that other group did?
Well, it depends on if that group is truly separate or if they are contracted with the practice. If they're contracted with the practice, but not necessarily W-2 employees as diabetic educators, then most of the payers would still let you bill for their services. And then there's also a pretty wide difference among the payers. Some want the diabetic educators to go through the credentialing process and have their own NPI number and bill under their own name. Some want that to be, still want their services to be billed under a responsible physician.
Okay.
I don't know if that's a very good answer, but it depends on the payer, and each one has a little bit different criteria. If there's a group that's doing the diabetes education that you're simply referring patients to, but they're not contracted with the practice to provide those services, and they're really truly independent, and the practice would not bill for that.
Okay. We have a couple of scenarios we're looking at. Like diabetic education we do in-house, but we are looking at outside groups for congestive heart failure education, and they do bill for the first visit. They have their own nurse practitioner come in, and they bill insurance for the first kind of group education visit, and that's why I was confused when you said the practice can sometimes bill. But no, I think what you said makes sense, that if it's really separate contractually, that the outside group bills and not the practice.
Right. So if you're referring them to this group that you know of that does congestive heart failure education in a group setting, but that entity that does the education, they're not affiliated with your practice at all, that group's going to do the billing.
We would sign a BAA and that's it.
Right, that's fine.
Okay.
So, and when I say that's fine, it's fine to sign a business associate agreement, but that doesn't necessarily make them contractors of your practice that would allow your practice to bill for their group education. But if you and a couple of other practices get together and contract with the diabetic educator who will provide group sessions to patients at your practice and to other practices, then because you are contracted with that educator to provide that service on your behalf that otherwise an employee of your practice could do, then you may be able to bill for those services.
Okay, that makes sense. I have another question. Can I ask that now?
Sure, absolutely.
Okay, so we offer clinic hours, like walk-in clinic hours on Saturdays. There's only mid-level providers, no physicians here. So based on what you said, I couldn't tell if that would be considered extended hours or not. I'm assuming not because it's always available.
It can be extended for CPC Plus to qualify as the alternative visit, making your practice available on the weekends. And then for purposes of reporting an additional code, can you go back one? So for purposes of reporting a code in addition to the office visit, 99051 might be an option because it's your regularly scheduled weekend hours that's happening.
Okay, that makes sense to me. That answers all my questions. Thank you.
Okay, you're welcome.
Anybody have any other questions for Richelle? All right. Well, thank you so much, everyone, for coming.
Thanks for joining us on the line, folks. Appreciate it.
Thank you very much.
Thank you.
Great day.